The fluorescent lights above operating room 7 flickered once, twice, then held steady, casting harsh shadows across the pale blue surgical drapes. My hands trembled inside latex gloves as I stared down at the monitor, displaying vitals that shouldn't exist. Heart rate, 42. Blood pressure, 80/50. Oxygen saturation, 91% and dropping. Dr. Reyes, the scrub nurse's voice cut through my paralysis. We need a decision. But I wasn't the attending. I wasn't even supposed to be here. 12 hours earlier, I'd been rotating through routine admissions on the medical floor, documenting lab values and updating treatment plans. Now I stood in an operating theater with a patient whose name I didn't know, whose condition defied every protocol I'd memorized, and whose life hung on words I hadn't earned the right to speak. The door behind me swung open with a pneumatic hiss. "Step back, doctor." I recognized the voice before I turned. Dr. Catherine Wright, chief of surgery. Her silver hair pulled back so tightly, it seemed to stretch her expression into permanent severity. She moved past me with the confidence of 3 decades in medicine, her eyes already scanning the monitors, the surgical field, the chaos I'd somehow inherited. "What happened?" she demanded. I opened my mouth to explain, but before I could form the words, the patient's monitor screamed a single sustained note, flatline. And that's when I realized what brought me to this moment wasn't a medical emergency. It was a lie I'd told 6 months ago. 6 months earlier, the automatic doors of St. Halstead Hospital slid open for the first time beneath my white coat, and I felt the weight of every sacrifice my parents had made pressing down on my shoulders like a physical thing. The lobby smelled of antiseptic and burnt coffee, a combination I would come to associate with exhaustion, breakthrough, and occasionally, grace. St. Halstead wasn't the biggest teaching hospital in the region, but it had a reputation. 500 beds, level 1 trauma center, research wings that published in journals my med school professors quoted like scripture. The building itself was a maze of glass and steel additions grafted onto a brick structure that dated back to 1947, creating an architectural timeline you could trace just by following the changing tile patterns on the floors. My residency badge felt too light in my pocket. Dr. Noah Reyes, PGY1, internal medicine, 27 years old, fluent in Spanish and medical jargon, competent in neither when it came to the actual practice of keeping people alive. "You're early." The voice came from my left, a tall woman in navy scrubs leaning against the admissions desk, holding a tablet like a shield. Her name tag read, Dr. Sarah Mitchell, PGY3. "First day enthusiasm or couldn't sleep?" "Both," I admitted. She smiled, but it didn't reach her eyes. "You'll get over the first part, the second gets worse." She pushed off from the desk and gestured toward the elevators. "Come on. Dr. Hammond wants all new residents in conference room B for orientation. Try not to look terrified. He feeds on fear." Dr. Richard Hammond turned out to be a man whose face looked like it had been carved from granite by someone who'd never heard of expressions. As medical director of internal medicine, he oversaw 17 residents, 43 medical students on rotation, and maintained a clinical schedule that would have killed a younger man. He was 62, I would later learn, and hadn't taken a vacation in 7 years. "Medicine," he began, standing at the front of the conference room as 8 of us first-year residents tried not to fidget in our seats, "is not about memorizing differential diagnoses or reciting drug interactions. Those are tools, but a hammer doesn't build a house." He clicked a remote, and the screen behind him illuminated with an image I recognized from textbooks, an X-ray showing a collapsed lung. This patient came through our doors 3 years ago. 22-year-old male, chest pain, shortness of breath. The attending on duty ordered this X-ray, saw the pneumothorax, inserted a chest tube, and sent him home 2 days later. Textbook case. Perfect outcome. Another click. Same patient, different angle. This is what they missed. The room went silent. There, barely visible beneath the rib cage, was a shadow that shouldn't exist. Stage 4 lymphoma. By the time they found it, 6 months later, treatment options were limited. He died 9 months after that first ER visit. Dr. Hammond turned off the screen and faced us. The attending who treated him had 15 years of experience, board certified, published researcher, and he missed it because he saw what he expected to see. He let that sink in before continuing. "You're residents. You know less than the nurses, less than the PAs, certainly less than the attendings you'll work under. And that's your advantage. You haven't learned what to ignore yet. You still see patients as mysteries to solve rather than checkboxes to complete." He paused. "Don't lose that. Your inexperience might be the most valuable thing you bring to this hospital. I wrote that down in my notebook, underlining it twice. It would become the most dangerous piece of advice I ever followed. The first week felt like drowning in slow motion. I learned the geography of St. Halstead through exhausted repetition. Medical floors on 3 through 7, ICUs on 8 and 9, surgical suites in the West Wing, emergency department in the basement level that somehow still had windows. I learned which elevators were fastest, which stairwells the attendings used to avoid running into administrators, and which vending machines accepted crumpled dollar bills at 3 a.m. I also learned about the invisible hierarchies that governed hospital life. Medical students were at the bottom, useful for running labs and fetching coffee. First-year residents like me occupied the next tier, trusted with basic decisions but always under supervision. Senior residents had actual autonomy. Fellows were specialists in training who looked at us with the weary patience of people who remembered being confused. Attendings were gods, speaking in acronyms and expecting us to translate divine wisdom into actionable orders. And then there were the nurses. Rita Kowalski found me on my third night shift, staring at a computer screen trying to figure out why my medication order kept getting rejected by the pharmacy system. "You're doing it wrong," she said, not unkindly. She leaned over my shoulder and pointed at a drop-down menu I hadn't noticed. "You have to specify the route of administration first. System won't let you proceed without it." "Thank you," I said, feeling my face flush with embarrassment. "Don't mention it. You're the one who actually listens when patients talk, right? I heard about you from day shift." I looked up at her, surprised. "What did they say?" "That you spent 45 minutes with Mr. Chen in 507 yesterday trying to understand why he kept refusing his diabetes medication." She smiled. "Turns out his sister died from insulin complications, and he's terrified of needles. Now he's on oral medication and actually taking it. The attending wanted to discharge him as non-compliant." "You asked why first." "I just thought there had to be a reason," I said quietly. "Most doctors stop thinking that after their first year," Rita replied. "They assume patients are difficult instead of scared. You keep asking why. We need more of that around here." She walked away before I could respond, leaving me with a warmth in my chest that felt like validation I hadn't known I needed. My first real diagnostic catch happened in week 2. A 79-year-old man named Robert Martinez came through the ER after a fall at home. No loss of consciousness, no obvious trauma beyond some bruising on his hip and shoulder. The ER attending diagnosed him with mechanical fall secondary to age-related balance issues, prescribed physical therapy, and prepared discharge paperwork. I was assigned to do the final assessment before he left. Mr. Martinez was sitting on the edge of the examination table when I entered, dressed in his street clothes, looking tired but alert. His daughter stood next to him, holding his jacket. "How are you feeling?" I asked. Fine. Ready to go home." I nodded, pulling up his chart on my tablet. Normal vital signs, labs unremarkable. CT of his head was negative for bleeding. Everything looked good, except, "Mr. Martinez, can you tell me what happened when you fell?" I was walking from the kitchen to the living room, and my legs just gave out. Nothing to trip over. Just went down. "Did you feel dizzy before it happened?" He hesitated. "Maybe. Hard to remember." "Did your chest feel strange? Any pressure or pain?" Another hesitation. Longer this time. His daughter's grip tightened on the jacket. "Dad's been saying his chest feels heavy for a few days," she said quietly. "But he wouldn't let me bring him in. Said it was just indigestion." Something cold settled in my stomach. I pulled up his EKG, the one they'd run in the ER as part of the standard workup. Normal sinus rhythm, no ST elevation, no obvious signs of acute cardiac event. But I kept looking. There, in leads 3 and AVF, subtle ST depression. So subtle that it could be normal variation. Could be. "Mr. Martinez, I'd like to keep you for observation," I said. "Run some additional tests. The other doctor said I could go home." "I know, but I'd feel better if we made sure your heart is okay. Just to be safe." He looked at his daughter, who nodded emphatically. "Okay," he agreed, "if you think it's necessary." I ordered a troponin level, a blood test that measures proteins released when heart muscle is damaged. I also put in for a cardiology consult and continuous cardiac monitoring. The ER attending found me an hour later, looking irritated. "Dr. Reyes, you held Mr. Martinez for additional workup?" "Yes, sir. I was concerned about his presentation. His CT was clean. His EKG was normal. You're adding unnecessary tests and delays based on what? A feeling?" Based on subtle EKG changes and a history of chest pressure that preceded a syncopal episode, I said, trying to keep my voice steady. I think he might be having a cardiac event that isn't showing classic presentation. You think? He repeated. How long have you been a doctor, Reyes? 2 weeks, sir. And you're overriding my clinical judgment based on 2 weeks of experience. I didn't know what to say to that. He was right. I was a brand new resident, second-guessing and attending with years of emergency medicine experience, but something was wrong. I knew it the way you know a word is misspelled, even though spell check says it's fine. I'm not overriding anything, I said finally. I'm following up on a concern. If I'm wrong, we run one unnecessary test and discharge him in a few hours. If I'm right, I didn't finish the sentence. I didn't have to. The attending stared at me for a long moment, then sighed. Your license is on the line for this. You understand that? Yes, sir. Fine. But when his troponin comes back normal and you've wasted everyone's time, you're writing the explanation in his chart. 3 hours later, Mr. Martinez's troponin came back elevated. Not dramatically high, but definitely abnormal. The EKG I ordered at hour 2 showed clearer ST changes. By hour 4, he was in the cardiac catheterization lab having an acute blockage in his right coronary artery, opened with a stent. The interventional cardiologist told me later that if we'd sent him home, he probably would have had a massive heart attack within 24 hours. Might have survived it. Might not have. Dr. Hammond heard about the case. He pulled me aside during afternoon rounds. The Martinez case. Walk me through your thinking. I explained about the subtle EKG changes, the history of chest pressure, the mechanism of the fall that didn't make sense for simple balance issues. And the ER attending told you it was nothing? He said the workup was negative, but you didn't agree. I didn't disagree with his findings, I said carefully. I just thought there might be more to find. Hammond nodded slowly. That's the difference between adequate medicine and good medicine. Adequate medicine follows the algorithm. You present with X, we test for Y. If Y is negative, we move on. Good medicine asks what we might be missing. It's messier, takes longer, often leads nowhere. He paused. But sometimes it saves lives. Good work, Reyes. My first 3 months at St. Halstead passed in a blur of overnight shifts, morning rounds, and the peculiar exhaustion that comes from making life or death decisions while running on 4 hours of sleep and vending machine coffee. I learned to present cases in 90 seconds, to recognize the subtle difference between a patient who was stable and one who was pretending to be, and to trust my instincts even when they contradicted what the computer said. I also learned about Marcus Chen. Marcus was a legend at St. Halstead, or depending on who you asked, a cautionary tale. At 39, he'd built the hospital's data analytics department from nothing, creating an algorithm that predicted patient deterioration with 87% accuracy. The system, called HALO, Hospital Analytics and Longitudinal Outcomes, monitored vitals, lab values, medication responses, and dozens of other variables, flagging patients who were at risk of crashing before traditional warning signs appeared. It had saved lives. Documented, verified, published lives. It had also, according to the nurses who'd been there longest, made doctors lazy. They stopped looking at patients, Rita told me one night during a lull in the chaos of the medical floor. She'd been a nurse at St. Halstead for 23 years, and she had the kind of institutional knowledge that made her more valuable than half the attendings. They look at the screen. Halo says green. They don't worry. Halo says red. They panic. But the screen doesn't tell you when a patient's scared. Doesn't tell you when they're hiding symptoms because they don't want to seem dramatic. I nodded, making notes in my mental catalog of things they don't teach in med school. You met Marcus yet? She asked. Not formally. Seen him in meetings. Brilliant man, truly. But he believes in his system the way some people believe in God. She adjusted the IV line for the patient in room 412, a 67-year-old woman recovering from pneumonia, vitals stable, Halo score green. Just remember, algorithms don't take oaths. We do. That conversation happened on a Tuesday. By Friday, everything had changed. I was finishing evening rounds when my pager went off. Not the standard beep, but the high-priority tone that meant someone needed me immediately. I checked the display. Conference room B. Urgent. Hammond. My first thought was that I'd made a mistake. Missed a diagnosis, given the wrong medication, forgotten to sign a critical order. I ran through my patient list mentally as I took the stairs 2 at a time, trying to identify which case had gone wrong. The conference room was empty except for Dr. Hammond and a man I recognized from hospital-wide meetings. Daniel Voss, CEO of St. Halstead Hospital. Voss was in his early 50s, always impeccably dressed, the kind of administrator who spoke in carefully constructed sentences that could mean 5 different things depending on who was listening. Dr. Reyes. Hammond gestured to a chair. Sit. I sat. Voss studied me for a moment, his expression unreadable. Dr. Hammond tells me you're one of his strongest first-year residents. High marks in clinical reasoning, excellent rapport with patients, and, this is the interesting part, you've caught 3 diagnostic errors in the past month that senior physicians missed. It wasn't phrased as a question, so I didn't respond. The fractured C2 vertebra in the 80-year-old fall patient, Hammond supplied. The attending diagnosed it as a simple neck strain. You ordered additional imaging. The patient kept touching their neck in a specific way, I said quietly. It seemed wrong. The misdiagnosed appendicitis in the 14-year-old, Voss continued. Attending thought it was gastroenteritis. Her pain moved, I explained. Started periumbilical, migrated to the right lower quadrant over 6 hours. Classic presentation, just slow developing. And the PE in the post-op patient that 3 nurses and 2 residents missed. I remembered that one vividly. A 49-year-old man, 3 days post-knee replacement, complaining of shoulder pain. Everyone attributed it to sleeping wrong in the hospital bed. I'd noticed he was breathing faster than baseline just by a few respirations per minute, and his oxygen saturation had dropped 1%. 1%. Within normal variation, technically, but something about the pattern felt wrong. The CT scan showed a pulmonary embolism. We'd caught it early enough that treatment was straightforward. I just listened, I said, uncomfortable with the attention. That's all. That's not all, Voss replied. He exchanged a glance with Hammond before continuing. Dr. Reyes, are you familiar with the hospital's HALO system? The predictive analytics program? Yes, sir. And do you use it? I hesitated. I check it, but I don't rely on it exclusively. Why not? The question felt like a test. I chose my words carefully. Because it's a tool, a valuable one, but it processes data, not context. It can't see the way a patient looks at their family. Can't hear the slight change in their breathing when they shift position. Can't feel the tension in a room when something's wrong, but no one can articulate what. Voss nodded slowly. 3 weeks ago, HALO underwent a major update. Marcus Chen's team implemented a new machine learning protocol that was supposed to increase prediction accuracy to 92%. The system has been live for 21 days. He pulled out a tablet and set it on the table between us. In those 21 days, we've had 4 critical incidents. 4 patients who HALO rated as low risk experienced sudden deterioration. 2 requiring emergency surgery, 1 requiring ICU intervention, 1 who didn't make it. He paused. That's a failure rate that shouldn't be statistically possible. My stomach tightened. Are you saying there's something wrong with the system? I'm saying, Voss replied carefully, that Marcus Chen is convinced there isn't. He's run diagnostics, checked the algorithms, reviewed the training data. According to him, these were outlier events, unavoidable, unpredictable, and not indicative of any systemic problem. But you don't agree. I don't know, he admitted. That's the problem. Marcus has access to data I don't understand. He speaks in statistical probabilities and confidence intervals. And he's brilliant. Genuinely, legitimately brilliant. This hospital wouldn't function at its current level without his systems. He leaned forward. But 4 critical incidents in 3 weeks, Dr. Reyes. That's not statistics. That's people. I looked at Dr. Hammond, trying to understand where this was going. The board has authorized an internal review, Voss continued. Independent assessment of HALO's recent performance. But it can't be someone from analytics. That's Marcus's department. It can't be an attending who's already invested in the system, and it can't be someone so senior that politics get in the way. He let that statement hang in the air. You want me to investigate? I asked slowly. I want you to observe, Voss corrected. For the next 2 weeks, you'll maintain your regular clinical duties, but you'll also review every case where HALO's prediction diverged from the clinical outcome. Talk to the patients, the nurses, the residents involved. Look for patterns, and tell me if there's something wrong that the data isn't showing. I felt my pulse quicken. Sir, I'm just a first-year resident. I'm not qualified to... That's exactly why I trust you, Voss interrupted. You haven't learned to worship the algorithm yet. You still trust your eyes. I looked at Hammond again. He gave me the slightest nod. If I find something, I said carefully, and it contradicts what Marcus's team is saying, then you report it to me directly, Voss replied. No one else. Not other residents, not attendings, not the analytics department. This stays between the 3 of us until we know what we're dealing with. He stood, signaling the meeting was over. "One more thing, Dr. Reyes. Marcus Chen is not your enemy. He's built something remarkable here. But remarkable things can fail in remarkable ways. Your job isn't to prove him wrong. Your job is to find the truth." I left the conference room feeling like I'd just been handed a weight I didn't know how to carry. The hallway outside was empty, the evening shift settling into its rhythm. Somewhere above me, patients were sleeping or trying to. Somewhere below, the emergency department was receiving its nightly influx of accidents and emergencies. And somewhere in the building, an algorithm was processing thousands of data points per second, trying to predict who would live and who would die. I wondered if it knew it was wrong. I wondered if it cared. The next morning, I received a secure access code to the hospital's incident review system and a list of 17 cases where Halo's predictions had been significantly wrong over the past month. 4 were the critical incidents Voss had mentioned. The other 13 were less dramatic. Patients who took longer to recover than predicted, readmissions that shouldn't have happened, complications that materialized despite green light ratings. I started with the fatality. Eleanor Vasquez, 63 years old, admitted for routine gallbladder surgery. Medical history significant for controlled hypertension, diet-controlled diabetes, and a heart that Halo rated as low risk based on a normal stress test 6 months prior. The surgery went perfectly. Recovery was textbook. Halo predicted a 72-hour hospital stay with a 94% probability of uncomplicated discharge. She arrested 48 hours post-op. The code team got her back, but the damage was done. Cardiac arrest secondary to a massive pulmonary embolism that no one had seen coming. She died 3 days later in the ICU, surrounded by family who kept asking how this could have happened, why the monitors didn't warn anyone, what went wrong. The official incident report said all the right things: unfortunate outcome, unpredictable complication, standard of care met at all stages. Halo's post-event analysis classified it as an unavoidable statistical outlier, the kind of event that occurs in 0.3% of similar cases despite optimal prevention protocols. But something bothered me about the timing. I pulled the full chart and started reading. Not just the official notes, but the nursing documentation, the vital sign trends, the medication administration records. I read for 3 hours, making notes, cross-referencing timeline events, looking for the detail that didn't fit. I found it in a nursing note from 36 hours post-op. Patient reports right calf discomfort. Attributes to positioning during surgery. Pedal pulses present bilaterally. No edema noted. Halo score green. No intervention required. My hands went cold. Right calf discomfort in a post-surgical patient. That's a potential sign of deep vein thrombosis, which can break loose and travel to the lungs, which becomes a pulmonary embolism. The nurse had documented it, had assessed it, had checked the Halo score and found it reassuring. And 12 hours later, Eleanor Vasquez was dead. I pulled the records for the other 3 critical incidents. Different patients, different conditions, different outcomes. But in each one, buried in the nursing notes or resident documentation, I found the same pattern. Subtle warning signs documented and dismissed because Halo said everything was fine. A patient complaining of unusual chest sensations, attributed to anxiety because Halo rated their cardiac risk as minimal. A surgical patient with decreasing urine output, dismissed as normal post-operative variation because Halo's renal function predictions showed no concern. A diabetic with rising blood sugar that didn't match Halo's glucose trend predictions, treated as a minor adjustment issue rather than a sign of infection that turned septic 3 days later. 4 patients, 4 sets of warning signs. 4 times the system said not to worry, and 4 times the system was catastrophically wrong. I spent the next 3 days buried in data. Between my regular clinical duties, morning rounds, patient assessments, discharge planning, I carved out hours to review charts, interview staff, and try to understand what Halo was seeing that I wasn't. Or more accurately, what Halo wasn't seeing that I was. The pattern became clearer the more I looked. Halo excelled at identifying patients in active crisis, sepsis developing, cardiac function declining, respiratory failure imminent. The algorithm caught these deteriorations early, often hours before human observers would notice. Lives were saved because of this capability. Real, documented lives, but the system had a blind spot. It struggled with the unexpected, with complications that didn't follow typical progression patterns, with patients who looked stable on paper but were hiding symptoms or experiencing unusual presentations of common problems. Eleanor Vasquez's pulmonary embolism should have been predictable, Post-surgical patient, limited mobility, multiple risk factors, but she'd been on standard prophylaxis. Her vitals remained stable. Nothing in the data suggested imminent disaster until the moment it arrived. The problem, I realized, wasn't that Halo was bad at prediction. It was that Halo had become too confident in its predictions. When it said a patient was low risk, clinicians believed it, and that belief became a filter through which they interpreted symptoms. Calf pain in a low-risk patient became positioning discomfort. Chest sensations in a low-risk patient became anxiety. Rising blood sugar in a low-risk patient became a medication adjustment issue. The algorithm didn't just provide risk assessment, it provided permission to stop worrying. And in medicine, permission to stop worrying can be permission to stop looking. I requested a meeting with Marcus Chen on the pretext of learning more about Halo for a research project I was supposedly developing. He agreed immediately. The analytics department loved when clinicians showed interest in their work. His office was exactly what I expected. Dual monitors displaying real-time patient data, whiteboards covered in equations I couldn't parse, and a coffee maker that looked like it required a PhD to operate. Marcus himself was younger than I'd imagined, maybe 40, with the kind of intense energy that suggested he ran on intellectual stimulation rather than sleep. Dr. Reyes, he shook my hand with enthusiasm. Dr. Hammond mentioned you had some interesting diagnostic catches lately. The pulmonary embolism case was particularly impressive. I saw the vital sign variation you picked up on. 0.8% drop in O2 saturation over 4 hours. That's signal detection in noise. Beautiful work. Thank you, I said, caught off guard by the genuine praise. That's actually related to what I wanted to discuss. I'm trying to understand how Halo processes subtle variations like that, how it distinguishes between meaningful signal and random noise. His eyes lit up. I'd asked the right question. For the next 40 minutes, Marcus walked me through the system's architecture. Machine learning algorithms trained on 5 years of patient data. Neural networks that identified patterns human observers couldn't see. Bayesian inference models that updated predictions in real time as new information became available. It was genuinely impressive, and genuinely beyond my ability to evaluate. The recent update, I ventured carefully. The one that pushed accuracy to 92%. What changed? We incorporated mortality data, he explained, pulling up a presentation on his screen. Before, Halo was trained primarily on patients who survived, either discharged home or transferred to long-term care. But that created a survivorship bias. The system was optimized for predicting recovery in patients who were going to recover anyway. He clicked to the next slide, showing a graph with confidence intervals that meant nothing to me. So we added 50,000 cases from the mortality database, patients who didn't make it. Terminal cancer, end-stage organ failure, traumatic injuries beyond intervention. The algorithm learned to recognize the patterns that predict death, not just the patterns that predict survival. And that improved accuracy? Dramatically. Halo can now identify high-risk patients earlier, which means earlier intervention, which means better outcomes. He smiled. We've probably saved 24 lives in the past 3 weeks just from earlier detection. I thought about Eleanor Vasquez and the 3 other critical incidents. But has the false negative rate changed? I asked. Patients Halo rates as low risk who turn out to need intervention? Something shifted in his expression. Not defensiveness exactly, but a kind of caution that hadn't been there before. False negatives are always a challenge in predictive modeling, he said carefully. We've actually reduced them overall, from 0.9% to 0.6%. That's a 33% improvement, but not zero. No system is perfect, Dr. Reyes. Human clinical judgment has a false negative rate around 5 to 8% depending on the study. Halo at 0.6% is better than even the best physicians. He leaned back in his chair. Why the interest in false negatives specifically? This was the moment I had to decide how honest to be. I'm just trying to understand the limitations, I said, keeping my voice neutral. For my own practice, I don't want to over-rely on a tool I don't fully understand. He nodded, seemingly satisfied with that answer. Smart approach. Halo is powerful, but it's not a replacement for clinical judgment. It's augmentation. Think of it like autopilot on a plane. Incredibly reliable, but the pilot still needs to watch the instruments. We talked for a few more minutes before I thanked him and left. Walking back to the medical floor, I thought about that analogy. Autopilot. Reliable, except when it's not. And when an autopilot fails, hundreds of people die. That night, I couldn't sleep. I lay in my apartment, a studio 20 minutes from the hospital, sparsely furnished because I spent more time at work than home. staring at the ceiling and thinking about patterns. Medical school had taught me to recognize patterns in disease. Fever plus cough plus chest x-ray infiltrate equals pneumonia. Crushing chest pain plus ST elevation equals heart attack. The human body breaks in predictable ways, and medicine is largely about matching symptoms to known patterns. But Halo took pattern recognition to another level. It saw patterns in data that humans couldn't perceive, subtle correlations between lab values, timing relationships between vital sign changes, probabilistic connections between risk factors and outcomes. The problem was that not everything followed patterns. Sometimes patients defied statistical expectations. Sometimes the body broke in new ways. And when that happened, Halo's confidence became a liability. I thought about Eleanor Vasquez again. The nurse who documented her calf pain had done exactly what they were trained to do. Assess, document, check the risk score, make a clinical judgment. The risk score said low. The clinical judgment followed. But what if the nurse had ignored the risk score? What if they'd treated the symptom as significant, despite Halo's reassurance? Eleanor might still be alive. I sat up, turned on the light, and started writing. Not a formal report yet, just notes, observations, questions I didn't have answers to. At 3 a.m., my phone buzzed with a text from Sarah Mitchell, the PGY3 who'd shown me around on my first day. "You awake?" "Unfortunately." "Rough case?" "Something like that." "Want to talk about it?" I hesitated. Voss had told me to keep this confidential, but Sarah was a senior resident, someone who'd been through what I was going through, someone who might have perspective I lacked. "Coffee tomorrow?" I typed. "Only if you're buying." We met at the hospital cafeteria before morning rounds. Sarah looked as tired as I felt, holding her coffee cup like it was the only thing keeping her upright. "You look like hell," she observed. "Thanks. You too." She laughed. "So, what's eating you? Patient die?" "Not one of mine, but yeah, someone died, and I think it might have been preventable." I told her about the review I was conducting, leaving out Voss's involvement and framing it as a personal investigation into Halo's accuracy. I told her about the patterns I'd found, the warning signs that had been documented and dismissed. Sarah listened without interrupting, her expression growing more serious as I talked. "You're saying Halo is missing things?" she asked finally. "I'm saying Halo is making us miss things. We trust it too much. When it says a patient is low risk, we stop looking for high-risk symptoms. That's not the algorithm's fault. That's clinical judgment failure." "Is it though?" I countered. "If a system is designed to guide clinical judgment, and that guidance leads to misdiagnoses, isn't that a design problem?" She took a long drink of coffee, thinking. "You know what you're suggesting, right? That one of the hospital's most successful innovations is flawed. That Marcus Chen's work, which has saved dozens of lives and gotten published in major journals, is actively harming patients. I'm not saying it's actively harming anyone. I'm saying it might have unintended consequences that need addressing. And you think a first-year resident is the person to address them?" The question stung because it was exactly what I'd been asking myself. "I think someone needs to ask questions," I said quietly. "And apparently that someone is me." Sarah studied me for a long moment. "Be careful, Noah. You're challenging a system that a lot of powerful people believe in. If you're right, you're a hero. If you're wrong, you're the resident who wasted everyone's time chasing ghosts. What if I don't know whether I'm right or wrong? Then you'd better figure it out before you go public with this." She stood, gathering her things. "And for what it's worth, I hope you're wrong. Because if you're right, it means we've been trusting the wrong thing for months. And that means people died who shouldn't have." She walked away, leaving me alone with my coffee and my doubts. Over the next week, I dove deeper into the cases. I interviewed nurses who'd cared for the patients, reviewed every vital sign trend, and cross-referenced Halo's predictions against the actual clinical timeline. The more I looked, the clearer the pattern became. Halo's new algorithm was better at predicting catastrophic deterioration, the patients circling the drain toward death, but it had become worse at catching the subtle, unexpected complications in low-risk patients. It was like the system had learned to see tsunamis so well that it started missing riptides. The problem was statistical. 0.6% false negative rate sounds fantastic. But when you're running predictions on 800 patients a day, 0.6% means almost 5 patients daily who the system says are fine but aren't. Most of those 5 patients probably had complications minor enough that staff caught them through routine care. But some didn't, and some of those ended up dead. I compiled everything into a report. Not technical, not accusatory, just a clear timeline of events correlated with Halo predictions. 13 pages, 47 specific examples. a pattern that couldn't be coincidence. I was about to send it to Voss when my pager went off. Critical patient, medical floor, room 412. I ran. The patient in room 412 was Mrs. Patterson, the same 67-year-old woman recovering from pneumonia that Rita had been caring for when we discussed Halo. I'd seen her twice a day for the past week. She'd been improving steadily. This morning's chest x-ray showed clearing infiltrates. Her oxygen saturation was 97% on room air. Halo rated her as green, predicted discharge in 24 hours. Now she was coding. I burst into the room to find Rita doing chest compressions, while another nurse bagged her, forcing oxygen into lungs that weren't moving on their own. The monitor showed ventricular tachycardia, a heart rhythm that wasn't compatible with consciousness, or if it continued, life. "What happened?" I demanded, snapping on gloves and moving to the bedside. "She was fine 10 minutes ago," Rita gasped between compressions, talking to her daughter on the phone. Then she said she felt dizzy and collapsed. The code team arrived. 2 residents, an attending I didn't recognize, a respiratory therapist. The attending took over, running the code with the mechanical efficiency of someone who'd done this 100 times. Defibrillation, medications, more compressions, misses. Patterson's heart converted back to normal rhythm after the second shock, but she didn't wake up. 2 hours later, Mrs. Patterson was in the ICU on a ventilator, and I was standing outside her room with Dr. Hammond and the attending who'd run the code, Dr. Yolanda Pierce, Chief of Critical Care. "Cardiac arrest secondary to massive PE," Dr. Pierce said, reviewing the CT scan on the computer screen. "Clot originated in the right leg, probably been forming for days. Should have been on prophylactic anticoagulation." "She was," I said quietly. "Standard DVT prophylaxis since admission. Compression stockings, subcutaneous heparin every 8 hours. Then this was just bad luck. Or bad prediction," I countered. I pulled up Halo on my tablet and showed them Mrs. Patterson's risk score. Green across the board. Less than 2% chance of thromboembolic complication. Dr. Pierce frowned. "Halo doesn't determine prophylaxis protocols. Standard of care says low-risk patients get minimal prophylaxis," I interrupted. "But what if Halo's definition of low risk is wrong?" Hammond gave me a sharp look. "Careful, Reyes." But I was past careful. I'd spent 2 weeks watching this pattern repeat itself, watching the system fail in ways no one wanted to acknowledge because the failure rate was statistically acceptable. "She's the 5th, I said. 5th critical incident in a month where Halo said everything was fine right up until it wasn't. And there are 8 others. Less dramatic, but following the same pattern. Subtle warning signs dismissed because the algorithm said not to worry. The algorithm," Dr. Pierce said coldly, "has saved more lives in the past year than you'll save in your entire career. You're a first-year resident. You don't have the experience to critique a system that's been validated by actual data science." "I'm not critiquing the system," I replied, trying to keep my voice steady. "I'm critiquing how we're using it. We've stopped looking at patients because we're too busy looking at screens." "That's enough," Hammond said, but there was something in his tone that wasn't quite a reprimand. Dr. Pierce walked away, shaking her head. Hammond waited until she was out of earshot before speaking. "You finished that report for Voss?" "Yes. Send it. Tonight." He paused. "And Reyes? Start documenting everything. Every conversation, every case review, every observation. This is about to get complicated." I sent the report at 11 p.m. from the residence lounge, then sat in the dark trying to convince myself I'd done the right thing. I'd just accused one of the hospital's most valuable systems of failure. I'd implied that Marcus Chen's work was flawed. I'd positioned myself against people with decades more experience and exponentially more institutional power. And I was a first-year resident who still had to look up drug dosages. My phone buzzed. Text from an unknown number. "Conference room B, 7 a.m. tomorrow. Voss." I didn't sleep that night. The conference room held 5 people the next morning. Voss, Hammond, Dr. Pierce, Marcus Chen, and me. The tension was thick enough to require surgical intervention. Voss had my report on the table in front of him. 13 pages that suddenly felt like an indictment. "Dr. Reyes," he began. "I asked you to observe. You've done more than that." "I documented what I saw," I said quietly. Marcus spoke up, his earlier friendliness replaced by barely controlled frustration. "What you documented is a cherry-picked selection of cases chosen specifically to support a predetermined conclusion. That's not science. That's confirmation bias. I reviewed every case where Halo's prediction differed from the clinical outcome. Selected from a dataset of over 15,000 predictions in the same time period, Marcus interrupted. 13 cases. That's less than 0.1%. You're judging an entire system based on statistical outliers. Those statistical outliers are people, I said, and one of them is dead. People die in hospitals, Dr. Pierce interjected. That's not Halo's fault. That's medicine. But Halo told us not to worry about them, I pressed. And we listened. We stopped doing the basic clinical assessments because the algorithm said they were low risk. That's not a system failure, Marcus argued. That's a clinical judgment failure. If physicians are blindly following predictions without using their own assessment, that's an education problem, not an algorithm problem. He wasn't wrong, and that made this harder. Voss held up a hand for silence. Dr. Chen, explain to me why the false negative rate increased after the mortality update. It didn't increase, Marcus replied. The overall false negative rate went from 0.9 to 0.6%. Overall, I said quietly, but not for low-risk patients. The room went silent. What do you mean? Voss asked. I pulled up a document on my tablet, the analysis I'd done at 3 a.m. when I couldn't sleep. Halo's mortality training improved its ability to identify high-risk patients heading toward deterioration, but it did that by becoming more confident in its low-risk predictions. When it says someone is low-risk now, it's more certain than it was before, which means the threshold for flagging concerns is higher. I showed them the graph I'd created, crude, probably statistically imperfect, but clear enough. Before the update, Halo would flag a patient as moderate risk if they showed subtle warning signs. After the update, those same signs have to be more pronounced before the system escalates the risk level. The algorithm learned that most low-risk patients stay low risk, so it became more reluctant to change that assessment. That's exactly what we wanted, Marcus said. Reduced false positives, fewer unnecessary interventions for patients who are actually fine, but increased false negatives for the patients who aren't, I replied. Halo became better at being confident and worse at being cautious. And in medicine, being wrong while confident is more dangerous than being wrong while cautious. Marcus opened his mouth to respond, but Voss spoke first. Mrs. Patterson, the patient from yesterday, what was her Halo score the morning she coded? Green, I said. 2% thromboembolic risk. And were there any documented warning signs before the arrest? I pulled up the nursing notes. She complained of right leg soreness 3 days ago, attributed to immobility. She mentioned feeling slightly short of breath 2 days ago during physical therapy, attributed to deconditioning. She had a heart rate increase of 8 beats per minute over baseline yesterday afternoon, attributed to anxiety about discharge. All documented, Voss noted. All dismissed, I added. Because Halo said they were insignificant, Hammond said quietly. It wasn't a question. Marcus stood abruptly. You're crucifying a system for doing exactly what it was designed to do. Provide risk stratification based on evidence-based medicine. Every single one of those symptoms has a dozen benign explanations. Should we start treating every patient with leg soreness as if they have a PE? That's not good medicine, that's paranoid medicine. No, I agreed. But we should treat every patient with multiple subtle warning signs as someone worth watching, not someone we reassure ourselves about by checking a green score on a screen. Dr. Pierce leaned forward. So what are you proposing? Shut down Halo? Return to pure clinical judgment that we know has a higher error rate? I'm proposing we remember what Halo is, I said. A tool, not a truth. Right now, we're letting it override clinical suspicion. We see something concerning, we check Halo, it says green, and we tell ourselves we're wrong. But sometimes we're right and the algorithm is wrong, and we need to trust that. Trust a first-year resident over a validated machine learning system? Dr. Pierce said skeptically. Trust what you see, I replied. Trust what the patient is telling you. Trust the small voice that says something isn't right. And use Halo as one input among many, not the final word. Voss had been silent for several minutes, reviewing the documents in front of him. When he finally spoke, his voice carried the weight of a decision that would affect hundreds of patients. Dr. Chen, I want a full audit of the mortality update. Specifically, I want to know if the false negative rate for low-risk patients has increased even if the overall rate decreased. Marcus's jaw tightened, but he nodded. Dr. Pierce, work with nursing leadership to develop a protocol for documenting clinical intuition separately from Halo scores. If a nurse or physician has a concern that isn't reflected in the algorithm, I want a formal mechanism for escalating that concern. She didn't look happy, but she nodded as well. And Dr. Hammond, I want Dr. Reyes embedded in the analytics review. He's got a perspective we need. Sir, I began. I'm not qualified. You're the only one who isn't invested in being right, Voss interrupted. Marcus is invested in his system. Pierce is invested in critical care protocols. Hammond is invested in medical education. You're invested in Mrs. Patterson not dying. He stood. Sometimes that's the only qualification that matters. The meeting ended. Marcus left without looking at me. Dr. Pierce followed, her displeasure evident in every step. Hammond lingered, waiting until we were alone. You know what you've done? He asked. Made enemies? Started something that can't be stopped. You've questioned the foundation of how this hospital makes clinical decisions. If you're right, everything changes. If you're wrong, he didn't finish the sentence. I know, I said quietly. Good, because being right won't protect you from the consequences of being right. You understand that? I nodded. Then let's find out which one you are. The audit took 3 weeks. Marcus's team pulled every Halo prediction from the past 6 months, cross-referenced them against clinical outcomes, and ran statistical analyses that generated reports I barely understood. But the conclusion was clear enough even for a first-year resident to grasp. The overall false negative rate had indeed decreased, but the false negative rate for patients initially flagged as low risk had increased by 43%. Halo had become excellent at identifying sick people, but it had become overconfident about healthy people, and some of those healthy people weren't actually healthy. The fix was technically simple, but philosophically complex. The algorithm's threshold for escalating concern was recalibrated. Sensitivity was increased at the cost of specificity, which meant more false positives, more unnecessary workups, more interventions for patients who turned out to be fine. It meant Halo would be wrong more often, but it would be wrong in safer ways. The nursing protocol Dr. Pierce developed became known informally as the Green Override, a structured process for documenting clinical concern independent of Halo scores. If a nurse or resident believed a patient needed closer monitoring despite a green rating, they could trigger a review by a senior physician who would make a clinical judgment call. In the first month after implementation, 63 green overrides were filed. 51 turned out to be unnecessary. 12 caught complications early. 3 saved lives. Mrs. Patterson survived. She spent 2 weeks in the ICU, another week on the medical floor, and went home with home health care and a story she told anyone who would listen about the machines that almost missed her and the people who didn't. She sent me a card 3 months later. It said simply, "Thank you for looking." I kept it in my locker, next to a photo of my parents and a list of drug interactions I still couldn't memorize. Marcus Chen and I never became friends, but we developed something like mutual respect. He understood that I wasn't attacking his work. I was advocating for its responsible use. I understood that he wasn't being defensive. He was protecting something he'd built with genuine care and genius. We had coffee once, a few weeks after the audit concluded. You know what the hardest part is? He asked, staring into his cup like it held answers. I built Halo to save lives, and it has. Hundreds of lives. But every system that's powerful enough to save lives is powerful enough to end them. And knowing that, living with that, it's harder than I expected. I can't imagine, I said honestly. You will, though, he replied. You're what, 6 months into residency? Give it time. You'll prescribe medications that have side effects. You'll recommend procedures that carry risks. You'll make decisions that save some patients and complicate things for others. The power to heal is inseparable from the power to harm. He finished his coffee and stood to leave, then paused. For what it's worth, you were right to push back. I was so focused on making Halo better that I stopped asking if I was making it better for the right things. He smiled slightly. Turns out, first-year residents are good for more than scut work. After he left, I sat alone in the cafeteria, watching the morning shift change. Nurses arriving tired from night shifts. Residents clutching coffee like lifelines. Attendings reviewing charts on tablets, their faces illuminated by screens showing data that might save lives or might blind them to what screens can't show. I thought about Eleanor Vasquez, who died because everyone trusted the wrong thing. I thought about Mrs. Patterson, who lived because someone didn't. And I thought about all the patients in between, the ones we'd never know about because the system worked or failed in ways too subtle to document. Dr. Hammond pulled me aside one afternoon during rounds, 3 weeks after Mrs. Patterson's discharge. You've been getting questions, he said. Not asked. Stated. Some, I admitted. Other residents want to know if they should trust Halo or not. And what do you tell them? That it's not about trust. It's about integration. Halo is a tool. So is a stethoscope. So is clinical experience. You use all of them together and you make the best decision you can with the information you have. He nodded slowly. Remember what I said on your first day? About inexperience being valuable? Yes, I need to amend that. He stopped walking and turned to face me. Inexperience is valuable when it's paired with humility. You could have come out of this review convinced that your judgment was superior to everyone else's. You could have become arrogant about being right. You didn't. That's what made this work. He started walking again, and I fell in step beside him. The patient in room 412 yesterday. The new admission with the complex heart failure. Did you see her yet? Yes. 71-year-old woman. EF of 20%, volume overloaded classic presentation. And her Halo score? Red. High risk for acute decompensation. Your assessment? I thought about it. I agree with Halo. But I also think she's more stable than the score suggests. She's been managing this condition for years. She knows her body. She knows when something's different. Right now, she's scared and uncomfortable, but she's not crashing. I'd rather treat aggressively and monitor closely than panic and over-intervene. Hammond smiled. You just integrated algorithm data with clinical judgment and patient input. That's what good medicine looks like. Keep doing that. We continued rounds. I presented 3 more patients, each one a puzzle of symptoms and data and human complexity that no algorithm could fully capture. Hammond corrected my assessment on one case, praised my thoroughness on another, and on the third simply nodded and said, "Trust your instincts on this one. You're seeing something I'm not." That night, I got a text from Rita. Heard about Mrs. P's card. Proud of you, Dr. Reyes. I smiled and pocketed my phone, then returned to the patient chart I was reviewing. A young man with persistent fever of unknown origin. Halo said moderate risk. The labs said probable viral syndrome. Everything pointed to observation and conservative management. But something about his story felt wrong. I spent an extra 30 minutes with him, asking questions, examining him more thoroughly than the algorithm suggested was necessary. I found nothing definitive, but I upgraded his monitoring protocol anyway. 2 days later, we diagnosed him with early-stage endocarditis, a bacterial infection of the heart valve that would have been catastrophic if we'd missed it. The attending asked me what made me suspicious. He kept touching his chest when he talked, I said. Just little gestures, unconscious, like his body knew something was wrong even if he couldn't articulate it. And his temperature pattern, it didn't match any standard fever curve. It was too regular, too predictable, felt manufactured somehow. The attending studied me. That's not in any textbook. No, sir. It's not in Halo either. But you saw it. I looked for it, I corrected. There's a difference. It's been a year now since I stood in that conference room and accused a computer of being wrong. Mrs. Patterson sends me a Christmas card. Marcus Chen's team published a paper on balancing sensitivity and specificity in clinical prediction algorithms, and I'm listed as a collaborator. Dr. Hammond uses the Halo case in his orientation lectures for new residents, and I've learned something that they don't teach in medical school. Medicine isn't about being right. It's about being right enough to help. The algorithm is right most of the time, but most of the time isn't the same as all of the time. And in the gap between those two phrases, lives exist. Real lives. Mrs. Patterson's life. Eleanor Vasquez's life that we couldn't save. The 12 patients whose green overrides caught complications before they became catastrophes. My parents came to visit last month. They stood in the hospital lobby where I'd first walked in a year ago, and my mother cried when she saw my name on the resident directory. My father asked me what I'd learned in my first year of residency. I told him about Halo, about Marcus and his brilliant algorithm, about Mrs. Patterson and her leg that ached and her breath that shortened and her heart rate that climbed. Subtle signs that meant nothing until they meant everything. So the computer was wrong? He asked. No, I said. The computer was confident. There's a difference. Being wrong is human, but being confident when you should be cautious, that's a design choice. He considered that, then smiled. Your mother and I made a design choice too. We chose to leave everything we knew so you could have opportunities we didn't. We chose to be confident that you would use those opportunities for good. Was it worth it? I asked, though I wasn't sure I wanted to hear the answer. Ask Mrs. Patterson, he replied. We walked through the hospital together, my father studying everything with the careful attention of someone seeing a world they'd sacrificed for, but never fully entered. My mother held my arm, her grip tight with pride and worry in equal measure. Do you like it? She asked finally. The work? I thought about that question, about the exhaustion and the doubt and the weight of decisions that determined whether people lived or died. about the mistakes I'd made and would continue to make, about the system I'd challenged and the enemies I'd probably created. Yes, I said, I like it, even the hard parts, maybe especially the hard parts. She kissed my cheek. Then we made the right choice. I'm still just a resident, still learning, still making mistakes and catching some of them and missing others. I check Halo every day. I trust it most days. But I've learned to trust other things too. The way a patient breathes when they're trying to convince you they're fine. The feeling in your chest when something doesn't add up, even though you can't articulate why. The value of inexperience paired with humility. The courage to say, I think the system is wrong when everyone around you is saying, trust the system. And the understanding that sometimes the most important thing you can do is look, not at the screen, at the patient. Sarah Mitchell was promoted to chief resident last month. She pulled me aside after the announcement and said, you know what I remember most about that conversation we had? When you asked if you should trust yourself or the algorithm, and I realized I didn't have a good answer. I'd stopped asking that question years ago. Have you found an answer? I asked. Yeah, both, and neither. You trust yourself to know when to trust the algorithm and when to question it. That's the skill nobody teaches because it can't be taught. You have to learn it by being wrong enough times to recognize the feeling before you're wrong. That's terrifying. That's medicine, she replied. Last week, I was presenting a case to the medical team during morning rounds. Complex patient, multiple comorbidities, Halo score yellow, moderate risk, standard monitoring. But something felt wrong. I couldn't articulate what. The vitals were stable, the labs were acceptable, the patient was comfortable. But in the way they held themselves, in the subtle shift of their breathing pattern, in the particular quality of their attention when I asked questions, something wasn't right. The attending asked me if I wanted to escalate the monitoring plan. I thought about Mrs. Patterson, about Eleanor Vasquez, about all the times confidence overrode caution. Yes, I said, I want continuous telemetry and Q2-hour vitals. Something's off. Based on what I see. The attending studied me for a moment, then nodded. Make it happen. 8 hours later, the patient went into atrial fibrillation with rapid ventricular response. We caught it immediately because of the telemetry. Treatment was straightforward. The patient converted back to normal rhythm and went home 3 days later. Halo's post-event analysis classified it as an unexpected development. Statistically unpredictable, clinically unavoidable, but we avoided it anyway, because someone looked. The new first-year residents arrived last week. 8 more doctors fresh from medical school, carrying the same mixture of excitement and terror I'd worn a year ago. Dr. Hammond asked me to participate in their orientation, to share what I'd learned. I stood at the front of Conference Room B, the same room where Voss had first asked me to investigate Halo, and looked at their eager, uncertain faces. You're going to make mistakes, I told them. Hundreds of mistakes. Some will be minor. Some will haunt you. But the biggest mistake you can make is to stop trusting your ability to see what others miss. I told them about Mrs. Patterson, about the algorithm that was right 92% of the time and catastrophically wrong the other 8%, about the importance of looking at patients instead of screens. One of them raised her hand. But how do we know when to trust our judgment over the data? We don't have enough experience to know what we're seeing. You're right, I agreed. You don't have enough experience, but you have something more important. You haven't learned what to ignore yet. You still ask why instead of accepting because, hold on to that. It's the most valuable thing you bring to this hospital. After the orientation, Dr. Hammond walked with me back to the medical floor. That was good, he said. Better than what I told you last year? You told me inexperience was valuable, and you proved it. But you also proved something else, that having the courage to question systems is what separates adequate doctors from exceptional ones. He paused at the elevator. You're going to be exceptional, Reyes, even when it's uncomfortable. Especially then. The elevator arrived, and I stepped in. As the doors closed, I caught a glimpse of my reflection in the polished metal. White coat rumpled from a long shift, stethoscope hanging around my neck, name badge that still felt like it belonged to someone more qualified. But I was learning to trust data and doubt it, learning to use tools without being used by them, learning that the practice of medicine is exactly that, practice, an ongoing process of refinement that never reaches perfection but constantly reaches for it. They say that medicine is as much art as science, that the best physicians combine data with intuition, evidence with experience, algorithms with instinct. They're right. But here's what they don't say. Sometimes the art part is just being brave enough to trust what you see, even when the science part says you're wrong. Sometimes the best decision you can make is to doubt the certainty of systems designed to make you certain. And sometimes, not often, but sometimes, being just a resident is exactly the qualification that matters. Because residents haven't learned what to ignore yet. We still see patients as mysteries to solve rather than checkboxes to complete. We still believe that every life is worth the extra 5 minutes of attention, the additional physical exam, the follow-up question that might seem unnecessary. We still remember why we're here, not to serve the algorithm, to serve the person the algorithm is trying to help. That's not inexperience. That's the only experience that actually matters. And it's what I hold on to every time I walk through those automatic doors into St. Halstead Hospital, ready for another shift of learning how much I don't know. The fluorescent lights still flicker in OR 7. The coffee still tastes burnt. Rita still knows more than half the attendings. And somewhere, in a room I haven't reached yet, there's a patient whose chart looks perfect, but whose life depends on someone noticing what the numbers don't say. Maybe that someone will be me. Maybe it'll be another resident, 6 months into their first year, terrified and uncertain and still naive enough to trust their eyes. Either way, I hope they have the courage to say what I said. Something's wrong. Even when everything says they're wrong for saying it. Especially then, because that's when it matters most. 2 nights ago, I was finishing a 30-hour shift when my pager went off. Not a code, not an emergency, just a simple request. Patient in 507 requesting Dr. Reyes. I was exhausted. My shift had officially ended an hour earlier. I had every reason to hand this off to the night resident, but I went. Room 507 held an 81-year-old man named William Foster, admitted 3 days ago with pneumonia, improving steadily. Halo score green, scheduled for discharge in the morning. I'd been his primary resident since admission. Mr. Foster, you needed something? He looked up from his bed, and I saw something in his expression that made me fully alert despite the exhaustion. I don't want to be dramatic, he said quietly, but something feels different. I moved to his bedside. Different how? I can't explain it. The nurses checked on me an hour ago, said everything looked good. The machines all say I'm fine. He touched his chest, but I don't feel fine. I pulled up his vitals on my tablet. Everything was indeed normal. Oxygen saturation 96%, heart rate 72, blood pressure within expected range, temperature normal. The Halo score was green, but William Foster was telling me something was wrong. I spent the next 15 minutes examining him, listening to his lungs, checking his legs for swelling, asking questions about symptoms so subtle they probably seemed irrelevant. I found nothing definitive, but I trusted him more than I trusted the data. Mr. Foster, I'm going to keep you another day. Run some additional tests. Something doesn't feel right to me either. But the computer says, the computer is a tool, I interrupted gently. You're a person, and right now, I'm listening to the person. I upgraded his monitoring, ordered additional labs, and notified the night resident to keep close watch. The next morning, we found a small pulmonary embolism, early enough that treatment was straightforward, but large enough that it would have been dangerous if we'd sent him home. William Foster went home 3 days later, healthy and grateful. He didn't send a card. He didn't need to. The look in his eyes when I told him we'd caught it was enough. This is what I've learned. Machines are brilliant at processing patterns, but they'll never be better than humans at recognizing when a pattern is about to break. They'll never feel the weight of responsibility that comes with saying, I'm worried, when the algorithm says, don't be. They'll never understand that medicine isn't about probability distributions and confidence intervals. It's about the person in the bed who just wants to go home to their family. And sometimes, not always, but sometimes, the first-year resident who still doesn't know what they're doing is exactly the person who sees what everyone else has learned to ignore. Daniel Voss told me that inexperience was valuable. He was right, but only because I was terrified enough to question it. Only because I still remember what Dr. Hammond said on my first day. Your inexperience might be the most valuable thing you bring to this hospital. Only because I haven't learned what to ignore. Not yet. And if I'm lucky, maybe I never will.